I think we can start now. And the title of this lecture is Theory and Practice of Mydriatics and Cycloplegics. And I believe that I would be able to justify the title today. We'll cover both the basic theory and the practice management. What are the good practices we should all follow? So what are mydriatics? Mydriatics are the agents that induce dilatation of the pupil. While cycloplegics, these are the agents which cause paralysis of the ciliary muscle, inhibiting the accommodation. But in the layman terms, we call them dilator. Ki dilator put kar do patient mein, which causes the widening of the pupil. But we should understand that there is a fundamental difference between a mydriatic and a cycloplegic. And when we what do we call an accommodation? Accommodation in the eye is of, I'll split it into two things. The accommodation created by the lens and accommodation of the pupil. When we focus from a far object to a near object, our eye accommodates to focus on the near object. And how it does? In the lens becomes more convex. The ciliary body contracts, the zonules become lax, the lens becomes more convex, and the converging power of the lens increases. And for the pupil, the sphincter muscles of the pupil, they contract and they block the peripheral rays which are coming from the periphery of the cornea. So what happens? They remove the spherical aberration and increases the depth of focus of the near object. So this is the accommodation. And those agents which block these two processes are known as cycloplegics. I think there is some problem in the... Yes, now it has been worked. We'll talk about all of these drugs which are shown on the screen, which we all use, but I want to say that I have no financial interest, interest for the disclosure. These are just for the pictorial depiction of the commercial drops which are available. So I'll start with the basic anatomy of the iris. Our iris, which forms the pupil. Iris has stroma. Iris has, apart from the stroma, iris has two muscles. One is dilator muscles, which are radially arranged, and the sphincter or the circular muscles, which are arranged circularly, right? And the neural system, which innervates the iris, is of two types: the sympathetic and the parasympathetic. Sympathetic pathway comes from the hypothalamus through the ciliospinal center of Budge to the superior cervical ganglion and innervates the radial muscles, the sphincter muscles, and the neurotransmitter here is noradrenaline or norepinephrine. While the parasympathetic innervation is through the pretectal nucleus from Edingle-Westphal nucleus via the third cranial nerve, which is oculomotor nerve, which synapses into the ciliary ganglion, and post-ganglionic fibers from the ciliary ganglion reaches the sphincter muscles and affects the M3 muscarinic receptors. And the neurotransmitter here is acetylcholine. I'll stop here and we'll again come to this slide, but the basic thing I want you to remember that the pupillary reaction or the muscles are under the autonomic nervous system control. Parasympathetic, the neurotransmitter is acetylcholine. The receptors are muscarinic receptors. For sympathetic innervation, the neurotransmitter is noradrenaline or norepinephrine. They innervates the radial muscle. Now, what are the indications for dilatation? Routine examination of all the patients. American Academy of Optometry guidelines say routine examination of all the patients requires a dilated fundus examination. Especially for patients aged 40 years or older, comprehensive eye examination is recommended annually, even in the absence of any diagnosed ocular condition. More frequently, monitoring with dilatation is indicated in patients with previous ocular pathology like high myopia. And why high myopia? Because we all know in high myopes, there are There can be some treatable lesions like lattices, holes, or maybe some breaks which are silent. To and we by dilating, we can see the periphery of the retina, and we can timely intervene and do the laser barrage, etc. Then patients with systemic conditions like diabetes, mellitus, and hypertension, we should always dilate them. Why? We should explain them that they can have ocular complications like diabetic retinopathy, hypertensive retinopathy. So they have to have a dilated fundus examination. This comes under the opportunistic screening of these ocular complications of these systemic conditions. Now, if the patients in your clinic comes with the symptoms and sign indicative of intraocular diseases like flashing lights, this can be a sign of impending retinal detachment, floaters. Sudden floaters may be a sign of posterior vitreous detachment, or maybe in elderly patient, it could be a sign of retinal detachment also. Reduced visual acuity may be a sign of BRVO, branch retinal vein occlusion with macular involvement, or maybe CRVO or optic neuritis. These all conditions demand dilated fundus examination. Apart from that, they have some diagnostic and therapeutic indications. Cycloplegic refraction in children, especially small children. We all know they have much more they accommodate than adults. So their accommodation masks the refractive errors like hypermetropia. So in what happens in hypermetropia, the eyeball is small, and the rays which are coming from the infinity, they converge behind the retina, but the child accommodates, converging power of the lens increases, and they converge the light so that they fall into the retina. But these accommodation can mask hypermetropia, the latent and the facultative and the manifest hypermetropia. To reveal that thing, we need cycloplegic refraction. We need dilatation for ophthalmoscopy, lasers if we want to do posterior segment lasers like pan-retinal photocoagulation, or before the cataract surgery, we all know. They have some therapeutic role in amblyopia therapy. We all know penalization by atropine. In an inflammatory condition of the eye known as uveitis, hometropine is a drug of choice. The mechanism of action is by doing the cycloplegia of the ciliary muscles, it removes the ciliary spasm and make patient pain-free. Also, it prevents because the iris is infiltrated with the inflammatory cells, it is muddy, it is reactionary, so it prevents the synechiae formation. And we all know myopia controlled by low dose atropine. Although I have just mentioned this, and if you just take note of any of these, and if you want to discuss about the role of atropine in myopia or amblyopia or whatever this thing, we can discuss in the later part of the lecture. Now, contraindications and precautions. Medico-legal litigation varies from country to country and type of practice, like you are a solo practitioner, independent practitioner, or you are in a group practice, or you are under the supervision of a ophthalmologist. It varies. And I think the best resource person here is Mr. Rajesh Wadhwa. He can guide us that what are the medical litigations associated with use of these drugs. As far as I know, you cannot prescribe even the low dose atropine without the consent or the supervision of an ophthalmologist. While about the cycloplegic and Mydriatic, Mr. Rajesh Wadhwa can throw the light on us. We should be careful about, like any other drug, like any other oral or the topical drug, they can also have allergic reactions, phenylephrine, cyclopentolate, and sensitivity to the preservatives like chlorbutyl. If you see the vial of a tropicamide or phenylephrine or any other dilator or cycloplegic drug, you will find a chlorbutyl preservative. It is very notorious to induce the allergic reaction in patients. Narrow anterior chamber. If you see that von Herrig grading shows you that the anterior chamber depth is very low, or you find occludable angus and gonioscopy, do not dilate, refrain from dilating. Presence of iris fixated intraocular lens or the anterior chamber IOL, the risk of IOL dislocation with pupillary dilatation does exist. Before gonioscopy or any procedures like laser PI in glaucoma patient workup, I have my own personal experience that the optometry staff, or in fact the junior ophthalmologists, they are so much conditioned that if the patient has come, we'll have to dilate before showing it to the senior. They just think over to the spinal level. They don't think to the cortical level. We should think what we are doing. Before doing, we should think that if the patient has come for the gonioscopy or the laser PI or any other glaucoma workup, we should not dilate the patient. And that is the difference between a learned eye healthcare provider and a non-learned eye healthcare provider. Documentation of the pupillary status, very, very important. I think this is the most important take-home message, and I have marked it red. Always assess and document the pupillary reaction before dilating. Assess both direct and consensual right reflex. I hope everyone should know. Direct is when we throw a light into the right eye, the pupil of the right eye constricts, as well as in consensual, the left eye is also constrict because of the ciliary ganglion and Edinger-Westphal nucleus. The neurons cross over to the other side. Pupillary status is a very important vital sign in patients with any intracranial pathology. Dilate with care in patients with recent history of any head trauma. Unilateral pharmacological mydriasis may masquerade as a sign of intracranial diseases like Hutchinson pupil, or I think this would be covered in the next part of the session where Dr. Rashmin Gandhi will elaborate more on Argyll Robertson pupil and these neuromuscular disorders of the eye. And some prescription medication as well as some recreational drugs can also cause people to dilate or constrict. And these have some medico-legal implication if you don't take history before dilating. Do not document the pupillary status. You may have some medico-legal repercussions. And we'll see what are the prescription medication. These are medications basically which are parasympathetic. Acetylcholine is a neurotransmitter which is associated with the parasympathetic control, and these are used in some medications for Parkinson disease and as well as before surgery to maintain the body's function under anesthesia. Apart from that, antidepressants like fluoxetines, these are selective serotonin reuptake inhibitors, very commonly used. Antihistaminics like antiallergics, benzodiazepines, decongestants like Dramamine, some motion sickness drugs, muscle relaxant used in anesthesia, and some earlier versions of anti-seizure medications like phenobarbital cause dilated pupils. Some illicit or recreational drugs. I wonder always that why these are called recreational drugs. What kind of they recreate, I don't know. They cause mydriasis, and the examples are amphetamines, which are stimulants, bath salts, cocaine, crack cocaine, ecstasy. Ketamine is a anesthetic, LSD and mescaline. And honestly, I don't know about details about. I just want know the names, and I believe that you also don't. I'm happy if you don't know the names of these drugs. Then opioids are the drugs which constrict the pupil. The common opioid medications include codeine, hydrocodone, and these are very common drugs. You will find them as a constituent of many cough syrups, which are used for the dry cough. Morphine, fentanyl, which is again a muscle relaxant used in anesthesia, methadone, and some illegal form of opioid include heroin and opium, which are, I think, very common. Now we'll come to we have touched somewhat of a theory. Now we'll come to the practical clinical consideration. We should always consider the side effect of mydriasis. We just put an eye drop in the patient and we do not consider about the side effects, blurred vision, especially for near work, for reading, office work, photophobia, decreased ability to recognize low contrast hazards and vision performance during the driving, increased glare sensitivity. These can contribute to angle closure event in patients with narrow anterior chamber, as I explained previously. So the patient should be advised accordingly. If the patient has not come with the attendant, so patient should be explained that if you have not come with the attendant or you have come with driving some vehicle, so there might be some problem. Counsel the patient and always take an informed consent. Other thing is that sometimes the people like they get frustrated that the I have put so many times the drug and the patient is not getting dilated. So the light color eye dilate faster and more completely than the darkly pigmented eye, because the iris pigment sequester the drug less. Then individual with poorly controlled diabetics, because of diabetes affects the small nerves and vessels. Increasing age also causes miotic pupil and increased latency time to dilate, uh, as well as injury to the brain and intake of certain drugs, which we have discussed just now, can lead to abnormally dilated or constricted pupils. It's a small bit of a practical tip that before dilatation, we can use a local anesthetic, which is proparacaine. This anesthetic decreases the blinking and tearing and changes the permeability of the epithelium to the mydriatic agent. It also reduces any burning sensation, so the patient will be more cooperative to you. But be cautious that these drugs can cause dry eye changes and epithelial toxicity, and never ever give these drugs to your patient to put unnecessarily. They are very dangerous. Now, after having known all these things, I think we should have our own clinical considerations, and we should develop our own best practice and standard protocols. So we should take a good history, visual acuity, pupillary reflexes, intraocular pressure, torchlight examination, or the slit lamp examination, which is best, and the anterior chamber angle. Recording and documentation is very important. Record the name of the pharmaceutical agent used in, including its concentration and time of the day. Counseling and consent is very important. And always wear a smile on your face when you are counseling and taking consent. Now, again, I told you that we'll again come to this diagram. And the reason is I want you to again revise that the parasympathetic nervous system has acetylcholine M3 receptors, and sympathetic have adrenergic receptors and the receptors, and the neurotransmitter is noradrenaline. And we have agonist drugs, parasympathomimetic drugs, which causes sphincter contraction, causing meiosis. An example is pilocarpine. Antagonists are anticholinergics, parasympatholytic, and there's also called anti-muscarinics. There are three names. They bind to these M3 receptors, causes pupillary sphincter inhibition, and causes mydriasis. They cause ciliary body inhibition, leading to cycloplegia. Examples are tropicamide, cyclopentolate, and atropine. And there is a very important and very good acronym I found. It's STOP ACH, scopolamine, tropicamide, atropine, cyclopentolate, and hometropine. I found it very useful. Then there are direct alpha adrenergic agonists. They bind directly to these alpha adrenergic receptors. This one, this receptor, and causes the dilatation. Example is phenylephrine, and this is a very classical, a diagram which you'll find in many of the textbooks of ophthalmology and optometry, where you will find their concentration peak time, recovery time, and the washout time. For atropine, it's the longest. For tropicamide, it's shortest. And for cyclopentolate, is in between, and that makes it an ideal drug for use for the cycloplegic effect. Now, what are the goals of our treatment? To deliver a full dose of drug to the patient without any systemic exposure, with patient safety and comfort. Preliminaries are patient education. It's not like कि कोई patient आया, आपने उसकी आंख में सीधा दवाई डाल दी, और वो भी बिल्कुल gently नहीं उसकी आंखों को इस तरीके से कर दी. No. Explain the purpose of the procedure. Inform the patient that you are going to instill the drops, wash hands, especially in the COVID times, use gloves. Inferior fornix method is when you just pull the inferior fornix like that, tilt the head backwards and retract the lid and put the eye drop into the inferior fornix. And be gentle and be empathetic with the patients. And as I already mentioned, that if you use anesthetic eye drops, it decreases the patient discomfort and maximize the drug penetration through the cornea. The solution in suspensions and inferior fornix method, it's a preferred method. It maximizes the ocular contact time, minimizes the drug loss, increases ocular absorption, and decreases the systematic absorption if we tell patient to close the eye or we ask patient to do the punctal occlusion for 2 to 3 minutes. Apart from that, subconjunctival infection, many of you may be knowing that we use Mydriatics. It is usually used for the advanced uveitis, where there are posterior synechia have developed. Other low anxiety techniques are medial canthus delivery, where we put the drop into the medial canthus of the anxious patient and tell patient to blink so that the drop spreads. Spray bottles, unfortunately, they are not available commercially in India. Cotton swabs saturated with the drugs. But these methods have some disadvantages, like you cannot meter the dose, and the wastage of the drug is very much high in these low anxiety techniques. Now, how do you assess that the completion of the cycloplegia has occurred? A common perception, the common learning is that when the pupil is dilated, that means the cycloplegia has occurred, which is not the case. The mydriasis and cycloplegia do not complete at the same time. Study says that unlike hometropine and tropicamide, in the case of cyclopentolate, the cycloplegia is completed prior to mydriasis. I wrote it's about 30 minutes as it was suggested by some study. But in practical thing, and if we read the Borish book, which is the gold standard, it says around if you put cyclopentolate, you should do the start the cycloplegic refraction at least after 1 hour. So if the pupillary dilatation is used to determine whether the cycloplegia is at the level of refraction, the refraction may be unnecessarily delayed or additional drug may be used unnecessarily. There will be wastage of drugs. We'll just put the drugs again and again. So how do we assess? We can assess it by the residual accommodation by the push-up test. I believe that we all know what is push-up test. Push-up test can be done by the pencil push-up test, and if we want to be more standardized, it can be done by the RAF ruler, which is Royal Air Force Academy ruler. Then now we'll come to the individual drugs one by one. Tropicamide, it's a drug of choice for routine mydriasis, fastest onset, shortest duration of action, equivalent mydriatic effect of 0.5% and 1%, but greater cycloplegia comes with 1%. Commercially, it is available as 1%, as well as in combination with phenylephrine, 0.8% tropicamide and 2.5% phenylephrine is most commonly used in India. Side effects are stinging upon instillation, which can be decreased by using the paracaine or the lignocaine before its application. Contraindications and precaution, no reported adverse systemic effects have been seen, though many of the preservative like chlorbutyl I've already explained can cause severe allergic reaction. It's very notorious. And I want to stress this point that if the patient comes to you and the patient has developed the signs of allergy, do not panic. Refer the patient to some health facility to get the injection of F-choline or hydrocortisone, which are anti-allergic, and ask the patient to wash the eyes, and always mention with a red bold marker on the prescription of the patient that patient is allergic to tropicamide or this cycloplegic drug so that again when the patient comes to some other health facility or eye facility or other eye healthcare provider, they know that the patient is allergic to this specific drug. Hometropine, clinically it is used as 2% weight by volume, used for cycloplegic refraction in older children, but its most important indication is treatment of uveitis. Its weak but prolonged effect and strong mydriatic effect makes it suitable for uveitis therapy. As I've already explained, that in, in uveitis, it causes a pain relief and prevent the formation of synechiae of the iris, posterior synechiae as well as the anterior synechiae of the iris. Then atropine, it's the most important Mydriatic cycloplegic which is available. When complete cycloplegia is needed, we use atropine. It is used as a 1% ointment in children, and it is commercially available as 1% drops or ointment. Clinical use of refraction, useful in case of suspected accommodative esotropia, especially in young children. In my practice, we always do the refraction of the child if below 2 years or maybe under 4 years of age with atropine. It's a best practice which is followed in our institution. And if somebody has, on uncover test, if you find that the patient has convergence or you suspect the accommodative esotropias, then definitely do the cycloplegic refraction under atropine. Also, the therapeutic therapy, penalization of the better seeing eye is done once a week. Installation of atropine is done to blur the image in the better seeing eye. And the studies, ATS study and amblyopia treatment study shows that it is equally efficacious as the patching. And I previously described that low dose atropine is also used for myopia progression control. Atropine toxicity, although rare, but can elicit with the following symptom: dry mouth, usually the first sign, fever, dry flushed skin, rapid pulse, disorientation and fever, and in fact CNS things. And though rare, but not uncommon. Two, and in the literature, if we find there are 3 episodes of death due to systemic absorption of atropine drops. But they also say that those children who unfortunately died have some or the other systemic underlying systemic condition. But we have to be very, very cautious if we use atropine. And now there is a question for the audience. You can, in your chat box, you may write the answer that what are the guidelines or what are the suggestions we give to the mother or the attendant of the child when we prescribe the atropine. And we always prescribe the atropine ointment and not drops. I think it is self-explanatory because atropine ointment has low chances of systemic absorption than the eye drops. And what I want to hear from the audience, that what advice you give to the mother. You can use the chat box. I give you half a minute for that. Now I'll tell you that what suggestion or what advice we give. Usually we give atropine 3 times a day for 3 days, and we advise mother to take the atropine ointment with less than a size of a grain, not more than a size of a grain. Like we say that चावल के दाने से भी हल्का ointment लेना है और बच्चे की inferior fornix में apply करना है दिन में 3 बार 3 दिन के लिए, and follow up after 3 days. And the mother is also advised that if the child develops fever, redness of the skin, or the rapid pulse, the drug should be discontinued at once, and the child should be referred to any pediatric health facility. Cyclopentolate, it is faster cycloplegia with rest residual accommodation, commercially available as 0.5%, 1%, and 2% solution. It is a drug of choice for routine cycloplegic refraction for routine in nearly all the age groups. Faster onset of action, shorter duration of effect, equally effective as atropine in case of older children. Full recovery of mydriasis and cycloplegia occurs within 24 hours. Cycloplegia occurs, as I said, at least 1 hour or the 45 to 60 minutes after the instillation. Scopolamine or hyoscine. This is not routinely used and not commercially available for the ocular application. Although dermal patches are used for motion sickness, it is contraindicated in small children, young children, because it easily crosses the blood-brain barrier and causes CNS effects, convulsions. We should take precautions and special considerations in elderly patient, Down syndrome, and young children. Although it's not relevant because it's not commercially available. Phenylephrine, as I already mentioned, that it is alpha adrenergic agonist, which works through the neurotransmitter noradrenaline via these sympathetic pathway. It causes it is the agonist of the alpha adrenergic receptors, which cause stimulation of the dilator muscles of the iris and causes mydriasis. And it is not cycloplegic because it does not paralyze the ciliary muscles. It is available in 2.5 and 10% solution. 2.5% phenylephrine is routinely used in combination with tropicamide, as I already told you. 10% is seldom used, and when it was used, it was useful for breaking the posterior synechiae, and majority of the side effects are associated with 10% solution used. It also causes the vasoconstriction of the smooth muscles of the conjunctival arterioles, so causes the blanching. And this is the other reason why it is used in combination with the tropicamide, because tropicamide causes congestion if you use plain tropicamide. But when you use the phenylephrine combination, it aids in the mydriasis as well as it causes the blanching, so increases the patient comfort. It also has a transient effect on the Mueller muscle. It causes stimulation and causes the transient widening of the palpebral aperture. Maximum mydriasis occurs at the 45-60 minute duration and can last up to 6 to 7 hours after the application. Risk and precautions are like it has a risk of adverse cardiovascular reactions frequently reported with the 10% solution. Should be used in caution with patient with cardiac history, definitive history of cardiac diseases, orthostatic hypotension, hypertension, and advanced arteriosclerosis. Also contraindicated in patient taking the MOA inhibitors, tricyclic antidepressants, and drugs like methyl dopa, which is commonly used for Parkinson's. So the crux is you always start with the good history, take visual acuity, see the direct and consensual light reflex, document that, then see the anterior chamber depth by the torchlight examination, do the slit examination, see whether there is any anterior chamber lens, iris fixated lens or not, then explain the procedure to the patient, be considerate to the patient, explain about the side effects of the Mydriatic and cycloplegic you are using, and then gently, following the good practice protocol, retract the eye, tilt the head, put the drops in the inferior fornix, and be gentle and empathetic during the whole process and wear the smile. These are the take-home messages from my side. Now, I thought that this is a great opportunity to add 2 more special conditions. Being an optometrist, you will be exposed or may have already been exposed to the assistant to the dilated examination for ROP screening. And there is a very much confusion that which mydriasis mydriasis should be used for these small premature children. So this table shows that phenylephrine, cyclopentolate, and tropicamide can be used. And data in neonate shows that these drugs can cause increased mean arterial pressure, cause CNS depression, and have many side effects. So what drugs should be used? And these are 2 drugs combination which are evidence-based. The studies are mentioned for your references. The combination of phenylephrine 2.5% and tropicamide 0.5% drop is very effective and safe Mydriatic combination for use in premature children during ROP screening. But the side effects of Mydriatic drop may be more common in children having systemic disease, respiratory distress syndrome. So these babies should be kept under observation. Otherwise, this combination is, I think, very feasible, commercially available in India, and should be used for routine ROP screenings. Other prepared combination is of cyclopentolate 0.2% and phenylephrine 1%. And they say that it appears to be Mydriatic for choice for preterm infants with dark iris. But it is not feasible because this combination is not commercially available. So focus yourself on this phenylephrine 2.5 with tropicamide 0.5% drop. Other special circumstances is Mydriatic in pregnancy. We all know that indications in pregnancy are pregnancy-induced hypertension, gestational diabetes mellitus, CSR, and in fact, macular edema is much more common during the pregnancy. And those who work in a hospital setting, they may find that referral comes from obstetric department routinely for the fundus examination of the pregnant female. So this table shows the FDA drug risk classification, and it is applied to every medicine used in medical science, not only these Mydriatic and all ophthalmic drugs. That the group A and schedule B drugs are usually safe. C are dicey, and if the therapeutic benefit outweighs the side effects, you should use C. The D is dicey and more in favor of not using, and X schedule are completely contraindicated. Unfortunately, the combination of tropicamide and phenylephrine as a Mydriatic can be safely used in pregnancy. And in every trimester, like first, second, third trimester, you can easily dilate the pregnant female with combination of this drug. And this is a review article named Ophthalmic Consideration in Pregnancy. You know, I just found this article very much interesting. And during the preparation of this slide, I find this article. And I urge you all to, you know, go through this article, not only for the Mydriatic and cycloplegic, but for all the ophthalmic drugs, which you will be, you know, encountering in your clinical day-to-day clinical practice, and it is very useful for your clinical practice. So just take a note of this. Thank you very much for your kind attention. And this is my email ID for any comments, any suggestions you want to, any feedback, if you want to give about this presentation, you're most welcome to mail me. Also, the Instagram and Facebook, I'm very fortunate to have many of the optometrist friends from optometry fraternity, friends and colleagues. So you're most welcome. And this is slide of Manthan Eye Healthcare Foundation. You can volunteer with us. You can go to this website, mehfindia.org, if you want to know more about it. And one of the vision for this year and coming years and years have passed is the eye health education and training for optometrists. And with our MOU with the Ansal University, we are pledged to increase and build, enhance the training for the optometrist, future optometrist. And I want, this is my vision that optometrist fraternity should learn the next upcoming batches of the optometry should be very, learned. They should be, education gives you self-confidence. If you have knowledge, then you can face any clinical challenge you have. But if you have no knowledge and it's just like that, okay, hame dilate karna hai, hame piche rehna hai, then nobody can save you. You have examples of legendary optometrists with you. Mr. Ajit Bhardwaj, Professor Monica, Rajesh Vadwasar is there. So these individual motivates me to study, to gain knowledge. And this is my passion, that optometric training and education should be uplifted to make optometry profession future bright in India, like US, UK, and I found that working in UK, I found that the potential in our student is much more than the potential at the UK thing, but optometrist there. Here I found the basics are more strong, but there is a need to refine them to make them more this thing. And my subject under the ophthalmology, which I am very much interested, are diabetic retinopathic screening, glaucoma, and public health. So we are in the stage of developing many modules in association with Ansal University, and those of you who are interested to join the course may contact Professor Monica Chaudhary for further information. Thank you so much.